Okay, for our next lecture, we're going to be talking about your chronic obstructive pulmonary disease, or what we term as your COPD. Well, mm, to start off, let's talk about the description of your COPD. So we have this is a disease of progressive. Let me underline that one. Progressive airflow limitation. Hence, we have your chronic airflow limitation, which includes your bronchial asthma plus your COPD. Chronic airflow limitation disorders. Okay? It is associated with abnormal inflammatory response of the lungs that is not completely reversible. Unfortunately, your COPD it's actually progressive. Once you're diagnosed to have this one, um, the effects or the anatomical structures that are going to happen abnormally is progressive in nature until such time that yun nga, if you do not manage it appropriately, you will end up having a respiratory failure. So this is not completely reversible because what is wrong there is your anatomical structures na natamaan mismo ng chronic airflow limitation problem na ito. So hence, we end up having patients suffering from pulmonary insufficiency, no oxygenation at all, okay, pulmonary hypertension because there's so much pressure there. And you also have your cor pulmonale, which is your right-sided heart failure that is associated with your respiratory problem. Okay? So that is the description of your COPD. Risk factors, pinaka-reasons why we have your COPD. Unang-una sa lahat, and this is a board exam question, it's always your cigarette smoking. Primary risk factor. Anybody who is a chain smoker for that matter, who has had like how many pack years of your cigarette smoking, they are very much at risk for having your COPD. Environmental air pollution, well, your cigarette smoking can either be secondhand also, or maybe primary smoker for that matter. Environmental air pollution includes, your smoke belching, occupational hazard if you're a driver, if you're a barker for that matter. Host factors. It runs in the family, unfortunately. With your alpha 1 antitrypsin deficiency, and you have your abnormal lung development, maybe siguro when you were a kid or when you're a baby, you were a preemie, your you have your premature development. Accelerated aging can also be a reason why we have your COPD. Actually, for everyone's information, most of those who have your COPD are your elderly population, especially for the men, for the male patients. Okay, accelerated aging. So we have two types of your COPD. The first one is what we call your CB, or your chronic bronchitis, pure chronic bronchitis. And we have another one, which is called your pure emphysema. Your chronic bronchitis, from the term itself, chronic, ibig sabihin nun, long-term, bronchitis, bronchial airway, itis, inflammation of your bronchial airways. Hence, it's not just talking about your large airways, but also your small airways. What you're going to see here is you have your mucus hypersecretions as a result of that inflammatory response. You will also have your inflammatory reaction and your chronic bronchitis. Yan. Sobrang laki. And it's not the structure, ha. We're talking about the inflammation that's ongoing here on your bronchium, large airways for that matter. Small airways are also likely going to be affected. So you have your peribronchial fibrosis. I have explained already what your fibrosis is. Nanigas, nag-scar dyan. Nanigas yung area na yan. You also have your airway obstruction, causing you to have not your chronic bronchitis in itself, but you have your chronic bronchiolitis because we're talking about your bronchioles. Okay, chronic, okay? So what's wrong here is that apart from having your edema, you also have very, um, very hyperactive mucus production, okay? Causing you to not really have any gas exchange, to happen because hindi makapasok yung ating oxygen. Next, we have your pure emphysema. What's wrong here? If your chronic bronchitis, ang target niyan are your airways. With your emphysema, the target here are your alveoli. With your alveoli, it loses your surfactant, your elastic coil. What happens here is that your alveoli also is going to have your hyperinflation. Di ba your alveoli, whenever you have your inspiration, it actually expands. And when you have your expiration, it actually deflates. That's the primary function of your alveoli because it facilitates the accommodation of your oxygen and the release of your carbon dioxide. Your alveoli works hand in hand along with your capillary membranes so that there would be proper diffusion and gas exchange there. However, with your emphysema, what's wrong there is everything is just hyperinflated. As in, yung tipong it has stuck itself into becoming inflated the whole time. Hence what you can see here, why? Because you have lost your elastic recoil. When we say elastic recoil, it has the chance or it has the capacity or capability of inflating and deflating depending on that particular gas exchange. But your alveoli, something is wrong with your alveoli. It has lost that elastic recoil, causing it to be just inflamed. I mean, not inflamed, but um, uh, inflated all the time. Yan yung problema sa ating emphysema. Okay? So, these are the components that's uh, characterized of your chronic bronchitis and that of your pure emphysema. Assessment findings sa pancephalocaudal examination of a patient who has your COPD. You have your cough and exertional dyspnea or your orthopnic position. As with any case of a patient who has your respiratory problem, you also have your wheezing and your crackles because why? There's just so much mucus production ongoing there. Prolonged expiration. Why do we have your prolonged expiration? Since in your chronic bronchitis and even in your emphysema, you do not have the entry of your oxygen. And since this is a chronic disorder, ibig sabihin nun, it's a long-term condition that the patient has already been accustomed to for a long period of time. Okay? Why do we have your prolonged expiration? Because there's trapping of your carbon dioxide in your patient's respiratory wall or in your respiratory tissues for that matter. Okay? CO2 is just very, very high in patients who have your chronic bronchitis and also your emphysema because there's no proper gas exchange there. Everything is just blocked off appropriately. If there is just, a very small opening, it's very, very small. And not all of those CO2 is actually being released into your system. A client who has your chronic bronchitis, by the way, since there is your obstruction and there is your inflammation, the patient has been living with your very high levels of your CO2 for a long period of time. And he has also been living with decreased levels of your O2 for a long period of time. It's quite uh, interesting to note how this person is able to live with that very low levels of oxygen and very high levels of your CO2. Diba? Likewise, with your emphysema, very high levels din ang CO2 natin dito. But more importantly, you do not have enough of your oxygen to be considered as your normal healthy individual with that percentage of level of oxygen. Hindi ba? When we have that for years and years, imagine mo, years and years ang pasyente mo nakakaramdam ng very high levels of your CO2 and very low levels of your O2. How can they survive? Why? Through compensatory mechanisms. Hindi ba? Okay? So, in order to compensate with that very high level of CO2. What is the attempt of the body to resolve this particular situation? It's through your prolonged expiration. With your prolonged expiration, ibig sabihin nun, mas mahaba. You have longer seconds or duration of exhaling. And this is because you'd like to attempt to remove the very high levels of your CO2. Okay? Despite the fact that meron kang very low levels of your O2. Actually, that low level of your O2 is a point of concern for patients who have your COPD. Okay? Di ba? Now, for any normal healthy individual, a person must have very high, enough levels of your oxygen and only a few amounts of your CO2. That's a normal normal healthy individual. O2 less CO2. Patients who have your COPD, it's baliktad. Okay? If in any case, for a normal healthy individual, okay, biglang tumaas yung CO2, that's a triggering effect that, oh, you need to breathe more because you have started to have very high levels of your CO2. Like for example, you try to submerge yourself in water. And di ba meron tayong games when we were kids, we have games with our friends to um, to have the longest stay underwater and not breathing. So whoever stays longer underwater wins the game. But with this particular game, you are actually depriving yourself of your oxygen because you're not breathing at all. Correct? So we go on, play the game, and we try to hold our breath for a longer period of time, trying to inhale as much oxygen because that's going to be, your bank of your oxygen underwater. So some of you might actually um, last for like 30 seconds, or maybe 20 seconds, 10 seconds for that matter. But you are forced to actually go up and not continue on because once you try to be underwater for longer than necessary, ang nangyayari doon is you are trying to build up your carbon dioxide. And that buildup of carbon dioxide underwater is also already a triggering drive. We call it your respiratory drive. That, hey, you should stop this game. Stop holding your breath. Your CO2 level is actually getting high. That's your respiratory drive for you to, you need to breathe. You need to breathe and get as much oxygen as you can. That's your respiratory drive. In a patient who has your COPD, this is very different. It's not your CO2 that's going to be your respiratory drive. It's your oxygen, which is going to be your respiratory drive. Yun yung magiging respiratory drive mo nito. Kasi nga, the low level of your oxygen here becomes your only stimulus to actually breathe. Once you have once this one is gone, you cannot breathe at all. You cannot breathe at all. You lose your respiratory drive if you attempt to have more oxygen. Dapat low level yung oxygen pa rin para sa mga pasyenteng merong COPD. Baliktad ang nangyayari sa COPD kasi your body, a patient's body with your COPD has become very much accustomed to very high levels of your CO2 and very low levels of your oxygen. So, in effect, you cannot give a person who has your COPD very high levels of your oxygen because if you do that, you are actually eliminating your triggering stimulus to breathe. You cannot mess with the oxygen level with patients who are suffering from your COPD, because that low level of your oxygen is the only way for that patient to actually breathe on his own and spontaneously ventilate on his own, because that is his respiratory drive. Okay? It has, a flip side effect when you have your COPD compared to when you have your normal situation. Okay? Naintindihan. Now, let's go back to your assessment. Sabi ko nga, prolonged expiration, it's because there's just so much CO2 level in your system. Sputum production is again resulted from your increased mucus production from your inflammatory response. Your weight loss is going to be a result of the patient's desire to breathe properly more. He thinks it's more important than actually eating. Hirap kang huminga eh. You do not have an extra energy to actually chew on food or even take in something. When in fact, you have difficulty breathing all on your own. Okay, that's why you have your weight loss. Barrel chest, emphysema. With your emphysema, what's wrong there? You have your hyperinflation of your alveoli. Ilang million of alveoli meron tayo sa isang lung, or even both of your lungs, right? So technically, that hyperinflation of your alveoli would result to this barrel chest. This is barrel chest, guys. Yeah. There's your anterior-posterior diameter. This is your normal, but this is your barrel chest. Yan, ang sinasabi kong barrel chest for your emphysema. By the way, for patients who have your chronic bronchitis, yan, we call them your blue bloaters. Kulang ang oxygen, di ba? Look at your nail beds. Di ba pink yan? If it's pink because there's enough of your tissue perfusion. But what is being perfused in a patient who has your chronic bronchitis? It's your carbon dioxide. There's not much oxygen there. Hence, you call them your blue bloaters. Okay? For patients who have your emphysema, again, because there is hyperinflation of your alveoli there, but there's not much of your oxygen, but there's hyperinflation of your alveoli. We call your emphysema as your pink puffers. Yeah. Bakit sila pula or even pink for that matter? That high level of your oxygen, high level of your carbon dioxide causes you to have your vasodilation, causing to have pooling of your blood in that specific area, causing may vasodilation, which causes you to have that pinkish color. Okay, pinkish color para sa mga pasyenteng merong emphysema. That's why you call them your pink puffers for your emphysema and blue bloaters for your chronic bronchitis. But there are instances wherein you can have both, by the way. Both. Para sa pasyenteng merong severe type of your COPD. Okay? Yung tipong malapit ng mag-respiratory failure. Yan. Okay, assessment. There is very obvious use of accessory muscles for breathing. You also have problems with your cardiac dysrhythmia. Apektado po ang ating puso dito. Congestion and your hyperinflation, emphysema, congestion, mucus production, respiratory acidosis, and hypoxemia. Why? There's not much oxygen, guys. There's just so much of your carbon dioxide. Okay? Interventions. Fowler's position and leaning forward, because this is how you are able to maximally expand your lungs. You provide assistance for the patient who has your COPD. Everything is just very burdensome for them. Mahirap para sa kanila ang mag-conduct or facilitate na activities of daily living. Why? Because breathing is a very important chore for them. They need to overcome that difficulty of breathing so that they could have enough, just enough of that oxygen that allows them to survive. Okay, so you provide assistance whenever they're going to do your ADLs. You allow activity if they can tolerate it. If not, then they should stop They should stop work. They should stop whatever they're doing, and they have to have rest. Administer your bronchodilators because why? There's obstruction. There's just edema. There's so much of your mucus production. You also have your intravenous corticosteroids because they are anti-inflammatory. Okay? And also, you have your mucolytics because of your mucus production in your alveoli or even in your bronchial airways. You need to have them expectorated as much as possible. Administer antibiotics if you have ear infection. Actually, because this is a chronic disorders, sa sobrang sanay na ng katawan ng pasyente merong COPD, pati yung mga causative agents mo na mga bacteria yan, gustong-gusto din nila ang environment na na-prepare ng anatomical structures na meron ang isang COPD patient. Ayun, it harbors your microorganisms fairly well because of the alterations in your anatomical structures of patients who have your COPD. Okay? Interventions, what can we do? Ang sabi ko kanina, we should not give, despite the fact that there is problems with breathing, there's problems with hypoxemia, and there's problems with your, ano to, your respiratory distress or even your perfusion, you cannot allow high flow oxygen. It's a big no-no, guys. Therefore, what can you do? If you are going to give your nasal cannula oxygen administration to your patients, the liters per minute that you should assign to your patient is only 1 to 2 liters per minute, and that's a board exam question. So please remember that one, guys. Low FiO2 lang po ang pwede nating maibigay para sa pasyente merong COPD, kundi mamamatay po sila kasi tinanggalan mo sila ng respiratory drive or stimulus to breathe. Okay? So how can we do something about your oxygenation? Enough lang ang kailangan nila. Okay? Enough lang talaga ang kailangan nila. Monitor your vital signs including your O2 saturation. That's a given for any type of respiratory concern. Provide respiratory treatment and your chest physiotherapy. What are these chest respiratory treatments na? Well, you have your medications to consider. Diaphragmatic and your abdominal breathing techniques and pursed lip breathing techniques kasi nahihirapan nga silang huminga. Everything is actually burdensome for them. So you actually teach them to do your DPE, your abdominal breathing technique kasi nga hirap mag-expand yung lungs nila. You also provide them, yes, placing them in orthopnic position will actually help in your lung expansion. And you also have to check for your sputum characteristics because baka malay mo, meron na palang infectious process dyan. We don't want infection to happen to an already very, very weak set of lungs of a COPD patient. Okay? Or else, well, the ending there is not too pleasant. You're going to have your acute respiratory distress, or maybe you're going to have your acute respiratory failure. Okay? Next. Yan. Ito yung sinasabi ko. If we are not allowed to give your liters very high flow of your oxygenation, what we can do for our patient is to provide the appropriate percentage of oxygen to our patient. Pwede ka naman magbigay ng ganun eh. Basta hindi lang high flow. High flow, ibig sabihin yung liters per minute. Alam nyo, for those of you who have been hospitalized and put on oxygen, kapag meron kang oxygen, tapos naka-nasal cannula, yung nasal cannula delivery method natin, try mo siyang itaas yung liters per minute natin. That's putting a lot of pressure, by the way, on your lungs. Okay, trying to increase your liters per minute, like for example, from 5 to 10. Okay, yes, pwede ka namang magbigay ng actually only 24 to 28% of your FiO2 is actually delivered via your nasal cannula. So sometimes we provide them via your face mask because it provides a higher percentage. Pero kahit na higher percentage, sobrang taas ang pressure na ini-introduce sa pasyente natin. That's why it is very important that we provide your Venturi mask, because your Venturi mask provides you the accurate percentage of FiO2 that we can provide to our patient with less pressure that we are going to administer to our patient. Okay? So, this is your Venturi mask. Ito to lalagay siya. Ayun. This is just an extension. Pero pwede siyang connect dito banda. Okay? Like this. Ganyan. Tapos, meron siyang calibration dito. It's too maliit. Pero, yun nga, each color has its own specific percentage of FiO2 that we can deliver to our patients. So, this is one of the better modes of oxygen delivery to our patient without sacrificing your without sacrificing that low flow of the liters that we can give to our patients. Okay? Interventions. Since sobrang dami ang secretions ng ating pasyente, it's important that we have to suction secretions PRN. Kung meron kang narinig via auscultation, or if you can see that there are secretions coming out of the patient's mouth, or you can hear loud crackles coming from the adventitious breath sounds, then you do your suctioning. But if there's no complaint at all, wag mo naman gawing bisyo yung pagsasuction sa pasyente mo. You know how very tiring and exhausting it is to be suctioned by another person? I've seen that one several times in the ICU. Sobrang nakakapagod po sa totoo lang. Tinitingnan ko pa lang yung mga pasyenteng sinasaksyon namin. Napapagod. Ako ang napapagod para sa kanila. Imagine you, okay, being inserted this catheter and then being being exposed to this undue pressure just so that they're going to suction you. Tapos mali-mali pa yung ginagawa ng mga nurses natin. Oh my God, that's like hellish of an experience for a patient who is already very weak because he is unable to breathe, or there is just so much secretions coming out of her or him. So suction only when it's necessary. Okay, and well, you need to check also your pulse oximeter for your auto saturation so that you can use that as a guide. Okay, next, monitor weight. Because you're losing a lot of weight, it's very important that you check for your nutrition also. Small frequent meals is very, very important because you know that the patient is unable to unable to eat properly kasi nga hirap para sa kanya yung huminga. High calorie, high protein diet because you're losing a lot of your weight. You need to provide them something which could replace those nutritions which were lost because of the disease. Encourage fluid intake of up to 3 liters a day unless contraindicated because it will facilitate again the loosening of your secretions, considering the fact that there's just so much of your secretions that are produced as a result of that chronic bronchitis or even your emphysema. Next, pulmonary rehabilitation. How can you help these people? Considering that this is already chronic disorder. So, ibig sabihin, long term, pati yung treatment nito, long term din. Hindi pa pwedeng one day confinement and then that's it, no more need, no. Hindi po ito madadaan lang ng gamot. You need to have a constant follow-up checkup of the patient, and at the same time, he needs to have lifestyle change. Unang-una, please remove smoking from the equation because that's the very reason why the patient is in the hospital or he is suffering from COPD. Next, you have to help the patient achieve good physical conditioning. Breathing exercise is also very important so that, that weak lung can actually have a capability of withstanding more pressure later on kung sakasakaling magkaroon man siya ng more strenuous activities para hindi siya mabilis mahirapan na huminga. The activity pacing is also very important because a client who has your COPD is always feeling exhausted all the time, fatigue all the time. So self-pacing of your activity, self-care activities also is encouraged, but with assistance, you are to provide that one. Patient education is a very important factor to consider here because without patient awareness of the things that he should do and not do, wala, mamamatay yung pasyente, no? We have so many of these COPD patients, especially the geriatric patients, who eventually die because they don't follow instructions. They refuse to be compliant with the medications. They refuse to follow what is proper and what is not. So pulmonary rehabilitation is very, very important. This kind of picture, I do not see this one in the clinical area, especially in public hospitals. Uh, I think it's important that sana in the future, we have a much better pulmonary rehabilitation program for our patients suffering from this type of diseases. Okay, next we have, yan. Now, what I've mentioned are those who are for discharge. But for example, you are still handling the patient in the clinical area. The less dangerous, or maybe less the condition, the situation or the scenario which has lesser chances of having your complications are the use of your non-invasive ventilation, or we might call it your BiPAP. Okay, mga BiPAP natin. These are the use of your masks, your oxygen delivery system, which will be able to ventilate the lungs without your invasive procedure. Yung intubation natin sa mechanical ventilation, those are invasive procedure, and there are so many complications that abound with your use of your mechanical ventilation. And it requires a more complicated intervention and management as opposed to having your non-invasive ventilation. But you can only use your NIV if your patient has your stable hemodynamics, and if there is your tolerance of your patient. Okay, there is tolerance of the patient's situation or scenario. So the goal is to normalize your arterial pH and return your PaCO2 to pre-exacerbation levels. Diba yung CO2 natin sobrang taas? Ngayon, prior to their admission in the hospital, naging okay naman sila eh. Naging tolerant naman yung katawan nila, but only to that certain extent. Kapag nasobrahan yung CO2 levels natin, causing you to have your exacerbation, doon sila napupunta sa hospital. So our goal is to normalize that arterial pH and to return your PCO2 even if it's high. But that level na hindi dangerous para sa pasyente na merong COPD. Okay? That is the goal of your non-invasive ventilation. So that ends our discussion about your COPD.